they're low potent, so they can certainly be used, although they can sometimes cause a low birth weight, things like that. The newer ones can cause similar side effects as the drug would have itself. So, for example, if somebody is taking olanzapine, the child may be born with some sort of sugar abnormality. Or if somebody is taking quetiapine or Seroquel, the child may be born sedated or may be sedated more so because, again, the drug is being secreted. So, whatever the property you have, as the person who's taking the medicine, 10-20% of that can go to the child. This is the fifth and the last one, and this usually surprises people. So paroxetine is 1, lithium is 2, valproic acid is 3, carbamazepine is 4, and benzodiazepines are 5. Why benzodiazepines? Most benzodiazepines are category D. Some people say clonazepam may be C. It is disputed though. And then there are some which are X, which we should not be using, period. Anybody in this group uses any of these X? Which ones? Restoril, Halcyon? Or Restoril is used still for sleep. I think Prosom and Dalmane and Doral may not be used a whole lot anymore, but Restoril I still see used, and sometimes Halcyon also. So X should never be used. Now, what do these drugs do? They can cause cleft lip and cleft palate. You can certainly argue that after the first trimester, organs are formed. Why cannot the patient take these medicines second and third trimester? Certainly can. Theoretically, they certainly can. First trimester is the biggest issue. Again, the problem is we don't know when a person becomes pregnant. So as in good faith, always, when you see a patient who is of reproductive age, you advise them not to use any of these medicines because by the time they come to you, it may be too late. And then not only it is unsafe, there could be a lawsuit also. So again, 5 medicines. Do we all remember the 5 medicines? Okay, so that's one thing, if you remember, that takes care of really bulk of the lecture because that's what we want you to do, to remember those 5. Rest is safe or safer. Lactation. So World Health Organization says that it's ideal for a mother to breastfeed the child for the first 6 months at least, and maybe up to 2 years, but first 6 months at least. Most psychiatric drugs, and most drugs per se, are lipid soluble, which means they pass easily through the breast milk. Highly bound drugs, drugs with large volume, and the drugs which are poorly lipid soluble would have a lower level in the breast milk. And I think the biggest thing we need to learn from just this slide is, if a child is being breastfed by the mother, there are few small things you can do which will give the child least amount of the medication concentration. Number 1, a lot of time, most of psychiatric medicines are given at night, at bedtime. So what you can do is feed the child hypothetically at 9 o'clock, take the medicine at 9:30. What will that do? Anytime you take a psychiatric medicine, 90% of the time, they have a peak level within an hour or 90 minutes. So peak level means you will have the highest concentration of medicine available at that time. You take it at 9 o'clock, 10:30 is the highest concentration. So if you have done that, meaning given the breast milk before that, you'll miss that part 1. Second, the child will be having some milk in the middle of the night a lot of times. That may be a time you can advise the mother to use formula, which sometimes they like to do it anyway. And by the time morning comes, the concentration drops down tremendously. Another small thing. Do you know the concept of foremilk and hindmilk? So if you're breastfeeding, the first 10 minutes of the milk which comes out of the breast is considered foremilk. F-O-R-E, foremilk. Foremilk has the lowest concentration of the medications. But it's still the same milk, but lowest concentration of the medications. The next 10 minutes of the milk is hind milk, which has the most concentration of the medication. So usually the breastfeeding is 20 minutes or so. What you can advise the mother is to breastfeed from one side for 10 minutes and then change to the other side. That way they will get foremilk from both the sides as opposed to the hind milk, which means while they will get the medication, they will get the least amount of medication in their breast, which will go to the patient. So if you remember a few of those things, that will certainly help. So lactation doesn't have categories, just like FDA, but the best drug, the best book, if you want to read for lactation, is Hale's book. Hale has the best and the most authenticated book when it comes to lactation. And American College of OB/GYN also has adapted this recommendation by Hales. So L1 is safest, L2 is safer, L3 is moderately safe, L4 is hazardous, and L5 is contraindicated. So we need to just remember the ones which are either L4 or L5, right? The rest is fine. So first thing is American Academy of Pediatricians and so have recommended against lithium. Why? Because hypothyroidism, because of serum urea and creatinine. So that is the reason I still, in my opinion, but I mentioned that as an outlier because I know some people like lithium and if they want to use it, that is fine. Risk would be first trimester, risk would be breastfeeding. Yes, second and third trimester, you are safer. But then how do you bridge that not given in the first trimester and not given breastfeeding? If you can manage that, that's perfectly fine, but otherwise that's an issue. So that's one, which is L4. Valproic acid is also considered L4 because thrombocytopenia can happen in the child. Actually, it used to be L3 in the previous version of the book. This version came out just last year. In the previous version of the book, it used to be L3, which was safer. But in 2014, when they had a revised edition, they changed it to L4. Another thing which was L4 in the previous edition was quetiapine and ziprasidone. But in the newer edition, they were all gone. So, sometimes things change. This chart is intense, but it tells you a lot about all these medications. So if you look at antidepressants, sertraline is L1, nifazidone is L4, but nifazidone is not necessarily used in US at least. I don't know about other places. Doxepin, surprisingly, is L5. What is doxepin? Cinequan. Anybody uses doxepin here? Doxepin is a drug which is used more so for sleep. It is also available as a different formulation for insomnia in US by the name Salinor, 3 and 6 milligram. Lithium, as I mentioned, is L4. Valproic acid, as I mentioned, is L4. Thyroidazine or Melaril. Anybody uses that? Okay. Thyroidazine or Melaril is also L4. I think the next group is surprising because this was not in the previous version, but in the newer version, they included that Strattera or atomoxetine is L4. Modafinil or Provigil is L4. There's no mention of Nuvigil, which is a newer version. And methamphetamines or Adderall-like products are L5. So that's serious. Now, in terms of sedatives, you have only flurazepam, which is L4. So if you remember just this chart, you basically cover the lactation. So truly, doxepin, L5, or your ADHD medications, lithium and valproic acid, thyroidazine, which a lot of people don't use, and rest you are necessarily safe. But thing is that every few years these things change based on the data available and so forth. But at the end, I think the best medicine if you're pregnant or lactating is truly no medicine. That is the best. Why? Because what we say today, maybe 5 years later, something changes and the whole even lecture changes because, again, I used to tell them L4 about quetiapine and ziprasidone, and it changed, so I had to revise that because research changes and things change, and that's the reason you have to keep up with what's happening because things definitely change. Okay. So with that, I will end and hope you guys will remember at least the don'ts for pregnancy and hope you will remember some of lactation also. In terms of antidepressants, anybody wants to guess which one is the safest antidepressant when it comes to pregnancy and lactation? Absolutely. Sertraline is the safest when it comes to pregnancy and lactation. And a lot of time patients or physicians think it's fluoxetine. And the reason it is that answer comes is that there is a lot of information available for fluoxetine. It doesn't mean that it's all good, but there's a lot of information available about that. So Zoloft is the best, or sertraline is the best when it comes to, and there's no commercial interest about that, so please remember that. And in terms of other mood stabilizers, so lamotrigine is your safest. Antipsychotics are all necessarily the same. There's not a whole lot. Mellaril is rarely used, and like I mentioned, but they're all almost the same. Okay. So with that, I will end, and if there are any questions. There's a question here, if we can have a mic.
How far can we rely on our personal experience, like anecdotal cases? I'll give one example. Bipolar manic patient informed me that she is pregnant on the 4th month. They cannot judge, or she did not realize that she is pregnant until the 4th month, and she was on heavy dose of haloperidol. I don't remember if it was antiparkinsonian or not. I think cogentine also, and the baby came okay. How far can we rely on this personal experience or anecdotal cases?
So first of all, obviously personal experience is important. In those cases, when we say that these medicines are category D or anything, nobody's saying that 100% of the people will develop any disease. It's only just like lithium, 1 in 1,000, 1 in 10,000. So that's rare, right? So again, the Depakote, 2 to 4% can have a neural tube defect. Only 2 to 4%. The other 98 to 96% are fine, right? So that's one thing. So when we even say it's not going to be all the people, I think the only issue with that is that if we give somebody, for example, as a psychiatrist, if I give a pregnant patient Depakote without knowing, without documenting, and something happens, there is a lawsuit coming for me. At least in US, there is a lawsuit coming for me. And it will be hard for me to defend that, especially if I haven't documented. Now, if I have documented that all the other medicines didn't work, this is the only thing which has worked, that's a different issue. Or I advise to the patient is willing to take the chance, that may be a different issue. Otherwise, it will become difficult to defend that.
If the patient comes to you after 3-4 months to tell you that I was on this medicine, like lithium, you will advise abortion?
No. We never advise that. That's the last one. If a patient comes after 4 months and patient is on lithium, the first thing is going back. If I'm the person who's prescribing lithium, I should ideally tell the patient who is of reproductive age that lithium can cause A, B, C, and you should not be using lithium. And if the patient said that's the only thing which worked, then you document that. And if the patient comes, you say, okay, now if you are really in the 4th month, then there's nothing to do right now. If, God forbid, there was a damage chance, that's done. You cannot do anything about it. You will do ultrasounds and all, but there's no point in doing anything right now, because stopping lithium at 4th month would not make any sense. Now, for lactation, you can advise them that these are the chances. If you continue the lithium, you can, but then you have to check the blood work of the child, and they can do that. It's no problem. Checking blood work is not that, it's cumbersome, bothersome, but it's not the end of the world, right? Any other questions? I put everybody to sleep? Actually, I was almost sleepy because I have a terrible jet lag because I just came today. And I came from US, then I went to Sri Lanka for a conference, and I came back, so I'm kind of in between. So, okay, thank you.